Cervical syndrome, we'll start with the short leg, doesn't matter which one's short, okay? So let's say that we have a right short, we're bringing it to flexion a little bit past 90 degrees, and it can either cross over and become longer or it can remain short, it doesn't matter. We'll bring them back down. She rotates the face to the right, and the short leg balances out, okay? Then we know that we have a right cervical syndrome. Back in center, she turns her face to the left, nothing happens, it remains short, okay? Put your face back in center. So the subluxation will be somewhere in the cervical spine, and we'll palpate bilateral along the facets for the tender pea-sized nodule. And if it's the right cervical syndrome, it's probably going to be on the left side. Okay? And more than likely it will be at C2. So if we find it at C2, we'll set the table to drop. You can leave the patient's head neutral, or you can have them to turn their head to the side of the cervical syndrome and palpate. It's entirely up to you. Let's say it's at C2, and we'll make contact with nail point 8 at the LPJ. Have the patient turn your face this way, please. And the table is set. The forearm rests along the patient's thoracic spine, and we're thrusting with both hands, like that. Okay? Put your face back in center. After the adjustment, we will do the post check, and if we've made a correction at this point, the legs should balance out. We will bring them into flexion, and they remain balanced. She rotates her face to the right, center, left, center, and they stay balanced, and we'll post palpate, okay? And we also could do this using toggle recoil. Okay? If we're doing toggle recoil, since it's on the left side, we'll have her turn your face this way. Turn your face this way.
Which way?
Toward me. Yes.
I'm sorry, I fell asleep for that.
Okay, yeah, wake up. Okay, if we're doing toggle recoil, we'll palpate up, we'll in with the possible like the LPJ, and toggle recoil for C2. Okay, back in the center. And we also palpate the atlas if it's not the lower cervical. So would you like to just sort of sit up a little bit for me? Swing your feet that way. And we'll palpate, for the levator superior oblique. Then we'll motion palpate and see if the atlas is moving like it should. If it's not, then instead of adjusting the axis of the lower cervical, we'll adjust atlas side posture toggle recoil. And I may give you like left cervical syndrome with C1 involvement. So that's what you would do. Turn the other way. We put the patient in the side posture. We'll set the cervical and thoracic section to drop. We got a high arch, toggle recoil, okay? And we use the appropriate torque. Now you also can take this from the rear. Just change nail hands. We're still contacting the TP. And toggle recoil.
You said drops?
Yeah, everything's with the drop, yeah. Everything in this class is with the drop.
And which
Except
cervical
C1
syndrome? Which cervical syndrome would that have been for, with Atlas?
We've done the right cervical syndrome.
Okay, so all these are for right cervical syndrome?
Yeah.
Okay.
Okay. Yeah, face down. So that's cervical syndrome. Any questions about that one? The brain move, and also I forgot to mention this. Ben mentioned this to me the last time we met. If you wanted to, you could stand at the head of the table and do that cervical break. Turn your face this way. And like that. And that's up to you. I don't like doing it that way, but if you want to do it like that, that's fine. Okay. Pelvic positive. With the pelvic positive, like cervical syndrome, we'll start with the short leg. We'll bring it into flexion, and if it's true pelvic positive, we're going to get some resistance on that right side of the short leg, and it balance out or cross over. More than likely, we'll cross over. She rotates the face right, nothing happens, back in the center, left, nothing happens, back in the center. So we know now that we have a true pelvic positive. We'll palpate the PSIS at the sacroiliac articulation. If it's a right one, we're driving toward the shoulder. If it's PIIN, we're driving more or less toward the kidney on the same side. And if it was PIEX, we would get on the same side and drive toward the opposite kidney. So if it's PI, we'll roll in, we'll set the drop, stabilize the opposite one, okay, and thrust PA out of S. And so IN, PIIN, we just change the line of drive a little bit, and thrust, okay. PIEX, we will get on the same side, stabilize, and thrust. And if it was chronic, to the point where this area also had gone AS, then we just position the episternal notch more or less in the center of the contact and stabilization point. And now we'll thrust with both hands, okay? This one's going PA S to I, this one's going PA out S. Okay? So after the adjustment, do the post check, the legs should balance. We'll bring them into flexion, and they balance. She rotates the face right, center, left, center, and they stay balanced. And we'll just post palpate. Okay? Pelvic positive, prone correction. PI, PIN, and PIX. Any question about that one? Everyone's okay with that? Okay, good. Okay, let's do the pelvic positive supine correction. Let's say that we have a left short, in this case. We bring it into flexion, and it crosses over, it becomes longer, and I'm not getting much resistance when I bring it into flexion. So I bring it back down. She turns the face right, center, left, center, and there's no change. I'll palpate, and now I want to do a supine correction, so I'll bring the table up. And as the patient goes from prone to supine, the first thing I'll do is check spinal balance, and I still should have the left short, okay? And I start palpating along the ASIS along the humeral ligament, pulling along down until I get to the point of which you can't hold it up, and that sort of confirms the fact that we have the anterior pubis instead of the PI, where the pivot point is at the top of the acetabulum instead of being in the center. So to do the adjustment, I'll pivot to the superior. My narrow hand is the superior hand. I roll right in over the pubic arch and the inguinal ligament, pointing toward the opposite foot. The table is set to release, and I'll thrust. At this point, the leg should balance out, okay? However, there's a possibility that I still may have a rotational component, either IN or EX, so if I have that, then I'll go ahead and fix that now. It's EX, you can stand on either side, doesn't matter. Set the table, correct the EX, or if it was IN, flex the leg, lift the foot completely off the table, move it medial, stabilize on the ASIS, and thrusting back down with the hand that's on the patella. Okay. So at this point, The feet are still balanced and the rotational component's taken out if we had that. So I'll bring it back up. Put it back in the prone position. And the legs are balanced. We'll bring them into flexion and they remain balanced. She rotates the face right, center, left, center, and they stay balanced. And post-pelvic. Pelvic positive supine. Everyone okay with that one? Okay. Pelvic negative. Now you know the negative can be either one or two parts. Okay, so we'll do them both. So let's say that on the pelvic negative, we have a right short. We bring it into flexion and it stays short. It may get a little shorter, but it will stay short. She rotates the face right, center, left, center, and there's no change. So cervicals are ruled out. Now we'll check trigger points. And we need to have enough trigger points present to proceed with the adjustment above and below the waist. Okay? We'll separate the knees, elevate the foot piece a little bit. We need a lot of IDS. We're contacting the inferior portion of the ischial tuberosity. We'll palpate, find it, thrust straight up toward that shoulder. Drop, the table drops down and forward. We'll check the legs. And if we have made a correction, at this point, they should be balanced. And if we still have some IN or EX, we'll fix that now. So if it's EX, we'll square up and contact the lateral PSIS, stabilizing the opposite ischial, thrust with the drop. And if it's an IN, we'll get on the opposite side, stabilize, and thrust. So the IN and EX, as well as the inferior ischium, has been taken care of. So the legs are balanced with no rotation. They're balanced in flexion. She rotates the face right, center, left, center, and there's no change. And we'll just post check. That's pelvic negative prone correction, one part. Okay, with INEX, prone. And we also could do a two-part. Let's say that we have a right short. We bring it into flexion and stays short. She rotates the face right, center, left, center. There's no change. And we have enough trigger points to proceed with the negative correction. Again, a lot of IDS. Thrust. Oh, now instead of the leg balancing out, the leg has become shorter. So I know then I've made it a little PI. So there are a couple of ways that you can correct this. You can stand on the opposite side, lift your leg a little bit. Lift, yeah. Come above the knee, take the drop, thrust for the PI. Okay? If it was PIIN, we'll just change the line of drive like that. Okay? And if it was PIEX, we would have to get on the same side, lift your leg, and thrust like that. Okay? Another way that we could do that, second part, lift your leg, cradle it, interlock the fingers, position the elbow on the PSIS. If it's PI, thrust with the drop, PIIN, PIEX. So now, after doing the second part of the correction, the legs are now balanced. We will bring them into flexion and they're balanced. She rotates the face right, center, left, center, and they stay balanced. And we'll post check through. Okay? Everyone okay with that? Okay.
patients and.
Well, I'm earning my $2 today.
Spots on the wall, right?
Okay, before I do supine, I'm gonna go ahead and do sacrum, okay? The lumbar, okay? So let's say that we have a right short, we bring it into flexion, and it stays short. She rotates the face right, center, left, center, and nothing happens. Check trigger points. Trigger points are absent. And I know they have a problem at the fifth lumbar area. Okay, so Victoria, would you get up, please? And straddle the table. Move up toward the headpiece. Okay, patient straddles the headpiece, locking the knees along the headpiece. If you have to elevate it, you just raise it up a little bit. The doctor's behind the patient. Also straddling the table. Bring this on with that. Okay, the other one over. We're making contact with the pisiform. Rotate the patient, lean forward just a little bit until they become engaged, and then thrust P-Day. Okay? Lie back down, please. That was one way that you could do it. Or you could do it with the patients pronated without even getting them up, okay? You stand on either side, doesn't matter. Make the contact, and since it's on the right, which would be a PL, then we'll set the drop, thrust. Or if you want to stand this way, you can stand this way, thrust, drop, okay? Or if you want to stand on the other side, you stand on the other side, okay? That's lumbar. Question about that one? Then we'll do the post check. Okay, so post check, after adjustment, they're balanced. Balanced. She rotates the face right, center, left, center, and they stay balanced. We never had trigger points, so now we don't need to check those, okay? But we will palpate the lumbar. Okay. Pelvic negative with sacral involvement. So let's say that we have a right short. We bring it into flexion and it stays short. The patient rotates the face right, center, left, center. No change. We'll check trigger points. Trigger points are absent. Now we'll check for rotation of the fifth lumbar. Fifth lumbar seems okay. Now we'll check sacral restriction. We'll stabilize the base of the sacrum and instruct the patient to lock your knee and lift this leg up for me, okay? Okay, lift that one. And on the side of involvement, most of the time you'll get sacral restriction if there's sacral involvement, okay? We'll move this leg over a little bit. And at the knee, we'll cross the involved leg over the uninvolved leg, okay? We can stand on either side, pivot to the inferior or superior. This side opens up the articulation when you cross the leg. When I make contact on the opposite side on the PSIS, that will open up that to release it on that side. And this hand's on the apex, like that, and the hand that's on the apex of the sacrum, I'll get a little bit of counterclockwise torque into it, like that, scissors type move. Okay? Or I can stand this way if you'd like to. Do the same thing, or you can get on the opposite side of involvement. So you're still contacting the same points, doing that. Or you could pivot to the inferior. Yeah, whichever way you prefer. So after the adjustment, at this point, the legs should balance out. We'll bring them into flexion and they remain balanced. She rotates the face right, center, left, center, and they stay balanced. We never had trigger points. We never had anything going on with the lumbar, so there's no reason to post-check that. But we'll post-check the sacrum. Okay. Negative with sacral involvement. Question? Okay. Negative supine. I think you've done everything except that, right? Okay. Let's say that we have a right short. We bring it into flexion and it stays short. She rotates the face right, center, left, center, and there's no change. And we have enough trigger points to proceed with the adjustment, but instead of doing a prone, we want to do a supine. I'm going to bring you up, Victoria. And like the pelvic positive, when we go from prone to supine, the first thing that we do is check spinal balance. Okay? So we started with the right short. We still should have the right short supine. And there's some supine trigger points that you can check if you want to, the opposite great toe on the medial and lateral side. Okay? Already checked the knee, pubic arch, costal, sternal junction on the opposite side. Okay? They may be present. So we'll flex the leg. The doctor's pivot to the inferior, and the patient's leg just rests on the doctor's thigh. And with the heel of the hand, we're on the ASIS, nail point 8, we're on the issue 2, the arm is level with the table, we're thrusting straight up. The table drops down and forward. We check the legs. Now, if they're balanced, we'll stop. Okay? Like to one part, and if we have INEX, we'll go ahead and fix that. But if they're not balanced, then we know that we've created a PI on that side, okay? Just like we've done prone, so the way we'll fix that, we'll stabilize the opposite ilium, and with the thenar, we'll get right on the pubic arch and the angular ligament, position the episternal notch where it's superior to the contact point, like this, and we're thrusting A to P, S to I, if you want to do it that way. Or you could just turn around. We're still using the thenar. We'll just change hands, and we're doing the same thing. S to I, A to P. And since it's on the left side, we can get a little torque into the thrust. It will be a little clockwise torque. Okay? And after that, the leg should balance out. We still may have IN or EX. Then we'll go ahead and fix that like we've always done. Okay? Post-shake trigger points. Put the patient back in the prone position. And do the post check. At this point, the legs are balanced. The rotational components taken out, if we had any. We will bring them into flexion, and they're balanced. She rotates the face right, center, left, center, and they're balanced. And post check prone stress points. Okay? And I think that's everything that we've done up to this point.